Welcome by Batson.
компьютер автоматик гэсэн байсан. Автоматик компьютерээр өгсөн байсан юм уу?
Hello, Brian Batson. How you doing? Is your camera working? Are you there, Brian Batson? Hello, can you hear me, Dr. Arman? You have to come in from the panel. We don't start for 10 minutes. Hello, Brian Batson, are you there? Hello, good morning. Dr. Mukherjee, good morning. Can you hear me? Hello, good morning.
Hello.
Hello, Dr. M, right?
Hello, John. Can you hear me?
Yes, I can. How you
Okay,
doing?
thank you. Thank you. Huh?
Yeah, we start in about five. We don't have to start on time. We can wait a few minutes. Okay, Sidipka? Yeah, you're muted. That's okay. Okay, Dr. Almond's here. Oh, you're giving the other presentation. So both the speakers are here. Okay. Byam Batson, can you come in? Can you hear me, Byam Batson? Oh, okay, so you
Yes,
can't.
there. How are you?
Good, hi, how you doing?
Now I'm working.
Oh, okay, I understand. You can't come on the camera, right?
Yes. Here's my king.
When are we starting Mongolia neurosurgery grand rounds?
Sorry. My.
We try to talk later, okay?
Okay.
We talk about it, okay?
Okay. How can how can I use camera?
Your camera's not on now. It looks like it's not connected, but that's okay. You don't have to. You don't have to.
Миний сайн уу? Миний үздэг хоёр хүч хаана байлаа? Нэгийнх нь хажуу нь өнгөрчлөө.
All right, Sudipka, you want to wait a few minutes?
Okay,
Yeah.
we can wait.
Yeah, let's wait a few minutes. You're not in a hurry, right?
No, no hurry.
So how you been?
We are fine here.
Okay, good.
Actually, I suffered from some seasonal fever, which causes severe respiratory tract infection also.
Okay, you kind of breaking up. I didn't hear everything.
This fever is right now ongoing here. ঠিক ব্যাপার ওরা তো ওপেন করতে পারবে
Wait, gosh, wait, hi.
Arman bhai, link available in PNS group.
Oh, Brian Batson there.
Hi. How are
Yeah,
you?
yeah, I want you to meet Sudipka. He's the head of pediatric neurosurgery in Bangladesh. Brian Batson's from Mongolia.
Nice to meet
Okay,
you.
nice.
Хүүхдээ үзье л да. Миний нөхөө.
Нөгөө шууд төлөв.
Тий.
За.
Нэг хэнийг үзчих. Солонгог нь ярих цаг.
Dr. Brian Batson.
Англи чадахгүй шүү дээ. Миний нэрийг Баянбацэн гэдэг.
Okay,
Хүүхд маань.
okay, Brian Batson, welcome, welcome.
Welcome. Now I examination one patient.
Okay, we're gonna start, Brian Batson. We're ready to start,
She
Dr.
had
Mukherjee?
We can start soon.
You want to start now?
Чи камера яаж нөгөө тийш нэргүүлэх вүлээ?
I'm sorry, are you talking to us, Brian Batson? Oh, okay, she's showing us a pediatric patient there, Dr. Sudipka.
Yes.
What kind of patient is that, Brian Batson? Can you present that patient?
Can you present the patient?
She's one month old. Хэд хоногийн өмнө шунт тавиуллаа. 10 years ago I operated BP shunt. За харах. Okay, in camera нэрсаа эргүүлж
Kind of
мэдгүй.
hard to understand, huh?
одоо би одоо перцент гэж авахгүй шүү дээ. Now this is. Can you see?
It was
Yes, we can see the patient, yes, and
Yeah, yeah. We saw there is incision in the pinch point.
attendance are fine.
Нэг тави пишантай харуулчих жоохон. На ингээд. Patient surgery 10 years ago, 10 days ago. За, одоо тэгээ яаж вэ? Нэг дулаан жоохон.
Okay, very nice. Appreciating.
That's good.
okay, soon we will be televising from Mongolia.
Okay, that is a very good opportunity for this webcast that we can exchange our view with different area people, doctor. Because
Yes.
Mongolia is far away from Bangladesh, but we can exchange our views.
Yes, we can exchange ideas. Good morning, Dr. Arman.
Good morning.
Okay, we're going to start, okay? I'm turning the Bayam Batson off. Okay. Let me see here. Okay. You're ready to let me get Bayam Batson. Why is she Bayam Batson? Oh, okay. Okay, are you ready to go?
So can we start?
Yeah, let's start. Okay. 10, 9, 8, 7. Okay, I'm sorry, Bayam Batson. I gotta mute you there. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have today the grand rounds of the Bangladesh Pediatric Neurosurgery organized by Dr. S.K. Mukherjee from Bangladesh. He's the head of the Neurosurgical Society in Bangladesh. I ran across him just on the internet. He says, let's do some pediatric neurosurgery webcasts. And I said, yeah, good idea. Well, good day, Sidipka. It's all yours.
Okay.
Could you please introduce yourself?
Me and our here. This is the third episode of webcast with Neurosurgical TV with our department, Pediatric Neurosurgery, in National
Okay, be patient. The connection
is a complicated procedure. Surgery sometimes causes complication and sometimes causes. Today we discuss on two topics actually. Complication of BP shunt by Dr. D.M. Arman. He is working as a faculty assistant professor of Department of Pediatric Neurosurgery. He has very long time experience type of hydropins, that is ideal BP shunt. So, and today we have two renowned panelists. One panelist is Professor Dr. M.D. Shafiqul Islam Alam. He is a renowned neurosurgeon. Another senior professor, Professor Dr. M.D. Abdullah Alamgir. He is a renowned neurosurgeon in our country also. So I request Dr. D.M. Arman, please present your topics, complication of BP shunt. Dr. D.M. Arman, please.
Can you hear me?
Yes, we can hear you.
I am sharing my screen.
Okay.
Sure.
Can you see my,
Yes, it's not presentation mode. Okay. Yeah, perfect, perfect.
thanks, Dr. S.K. Mukherjee. Thanks, John Bennett. Can I start?
Yes, you can start.
Welcome to session 3 of Pediatric Neurosurgery webinar, organized by Neurosurgical TV and Department of Pediatric Neurosurgery. I must thank to John Bennett and Dr. Sudipta Kumar Mukherjee. I am Dr. D.M. Arman, work as an assistant professor in Department of Pediatric Neurosurgery, going to present my talk on complications of BP shunt. This is our hospital, National Institute of Neurosciences, situated at Dhaka, capital of Bangladesh. This is 500-bed hospital. We, more than 40 neurosurgeons work here, near 3,000 operations done in last year. In the Department of Pediatric Neurosurgery, we did 538 neurosurgeries in 2022. From 2013 to till now, we did ventriculoperitoneal shunt 972. I did few studies regarding outcome, accuracy, and some complications. This is the article published in Bangladesh Journal of Neurosurgery and Journal of National Institute of Neurosciences, and few journal published by Dr. S.K. Mukherjee, hydrocephalus related with TOT infection and management of loculated hydrocephalus, published in different journals. And others study of outcome of BP shunt is in progress. Introduction. Ventriculoperitoneal shunt is one of the commonly performed neurosurgical procedure and most popular CSF diversion procedure worldwide for the treatment of hydrocephalus. Till now, the standard treatment of hydrocephalus is ventriculoperitoneal shunt. The technique of using the peritoneal cavity for CSF absorption in ventriculoperitoneal shunting was developed by Kaush in 1908. A wide range of complications can occur, such as shunt block, shunt infection, shunt migration, and various abdominal complications. The complications of ventriculoperitoneal shunt may lead to failure of the procedure, necessitating revision or reinsertion in most of the affected patients. BP shunt complications can be divided into 3 broad headings: mechanical failures are obstruction, fracture, disconnection, migration, and perforation of discus. Infections can be bacterial, parasitic, fungal. Functional failures are overdrainage, split ventricle syndrome, pseudocyst, ascites, and metastasis. Acute complications during insertion of proximal catheter. The less occur in shunt insertion, mostly intraparenchymal hemorrhage, more common if old ventricular catheter is removed. So caution must be taken to remove old ventricular catheter. It is firmly adherent to the brain parenchyma. So if not removed easily, please leave it in situ. Neurological injury may occur, usually transient. Hemiparesis is possible if the catheter traverses the internal capsule. Abdominal visceral injury, like perforation of intestine, can occur after placement of of a peritoneal shunt. This is uncommon complication. This is the most common BP shunt complications is shunt malfunction. Failure rate in the first 6 months of life to be higher than that for children older than 6 months. Patient with shunt malfunction presented with symptoms and signs of increased ICP like vomiting, headache, irritability, sleepiness, increased head circumference, bulged or tense anterofrontalis, sixth nerve palsy, and papilledema. Shunt block or obstruction, 3 types. This is proximal blockage, bulb obstruction, and distal obstruction. Proximal obstruction is common. Cause is catheter adhering to the wall or embedded in the correct plexus. So during shunt insertion, accuracy is important. In our small study, we found in our hospital, accuracy rate is only 39%. Accuracy can be increased with aid of perioperative ultrasonography or navigation guided shunt insertion. Bulb obstruction is less common due to cellular debris or blood get into the ventricular catheter, passes into the bulb or obstructs the bulb. Distal obstruction, occlusion by momentum or trapping of debris. In shunt obstruction, shunt patency assessment, we can do shuntogram. In literature, different articles, shunt malfunction rate is varies. In our study, BP shunt malfunction was 3.17%. How can we manage the shunt obstruction? If upper end is blocked, treatment is revision of upper end, reposition of the ventricular catheter. If lower end is blocked, treatment is re-explore the abdominal site, check any occlusion, reinsertion in ipsilateral site or contralateral site. When child come with BP shunt malfunction, we try to assess OFC, palpate anterofrontonally, and see the bulb functioning or not by pressing fingers over the bulb. If bulb is collapsed and withdrawn after withdrawal of pressure, it refills. That means it seems to be functional shunt. If after withdrawal of pressure, it remains collapsed, that means upper end is blocked. And when it feels tight, it seems to be lower end block. After revision of the shunt, when revision does not work or patient complained of raised ICP, treatment is insertion of new shunt or endoscopic third ventriculostomy. Second most common complications of the BP shunt is shunt infection. The majority of the shunt infections occur within the first few weeks to several months after BP shunt placement. Although late shunt infections are observed as well, the most common isolated organisms are Staphylococcus epidermidis, Staph aureus, Streptococci, E. coli, and Pseudomonas. Highest risk for shunt infections are premature neonates in whom the immune system is not fully developed. Shunt infection causes significant morbidity and mortality in children. Prevention of BP shunt infection is essential. After BP shunt surgery, we face varieties of complications. So, to prevent BP shunt infection, we follow a standard protocol to prevent BP shunt infection. Number one, we ensure limited personnel in operation theater, proper prophylactic antibiotic is given, proper painting the surgical site with povidone iodine and wait for 3 minutes, proper hand wash at least 3 minutes, wearing double gloves, Iovan grape is used, and injection gentamicin into the bulb and shunt catheter. Despite these measures, BP shunt infection is common. Patient with shunt infection presented with fever, infected wounds, infected shunt tract, parietal abscess, pus discharge from wound, cleft skin, brain abscess, subdural empyema. Picture shows redness over the shunt tract. This shunt tract often contains pus. This picture shows abdominal parietal abscess at the abdominal wound. We published our article. In our article, BP shunt infection was 3.17%. In several articles, infection rate is more. According to Infectious Disease Society of America guideline, optimum management of BP shunt infection is removal of the shunt, placement of EBD, intravenous antibiotics, then placement of a new shunt. Shunt placement is performed after sterile CSF culture is obtained. Relapse may occur, reinfection may occur. Relapse is defined infection with same pathogens within 3 months of antibiotics being stopped. Reinfection is defined infection with same or different pathogens after 3 months of antibiotics being stopped. Patients with shunt infection are more prone to subsequent infections than others. Infectious Disease Society of America guidelines recommend a total course of antibiotics of 10 to 14 days, 21 days for gram-negative pathogens. IDSA guidelines recommend that new shunt placed on day 3 after CSF is sterile for coagulase-negative staphylococci infection. On day 7 for QT bacterium, formerly named Propionibacterium acnes, and on day 10 for other pathogens. Rifampicin is used to decrease recurrence in staphylococcal infection. In some studies reported, intraventricular antibiotics and antibiotic impregnated shunts decrease the recurrence rate. In other studies reported, intraventricular antibiotics and antibiotic impregnated shunts did not decrease the recurrence. Another complication of BP shunt fracture or break. It is a rare complication. Shunt tract calcified then cracked. Most commonly occurs in the neck, detected on X-ray. Shunt series means series of X-ray such skull, neck, chest, and abdomen to detect the shunt break. For a while, CSF will pass through the fibrous sheath. This picture shows shunt break below the bulb. Below, there is no shunt is seen. After exploration, shunt break below the bulb. Shunt is functioning. Shunt break below the bulb, and peritoneal catheter is totally migrated into the peritoneal cavity. In the chest, no shunt tract is seen. After exploration, fibrous sheath around the shunt. At abdominal site, this is fibrous tract, contains no shunt. This picture showed disconnection above the bulb. In the neck, no shunt is seen. X-ray shows this is cranial end. Bulb is displaced downward. In between, no shunt is seen. This is disconnected. This is cranial end. No shunt in between. Bulb with peritoneal catheter is displaced downwards. This is another rare complication, transanal migration. Exact mechanism is not clear. Adherence of the catheter tip to the visceral wall, constant pressure of the catheter tip along with local inflammatory reaction lead to perforation of the wall of the viscera. Entrance of the tip in the lumen and peristaltic activity of the bowel carries it all the way to anus and external surface. Poor general condition of the patient with weakening of the bowel wall, firm end of the peritoneal catheter thought to be responsible for transanal migration. Infants with myelomeningocele having thin bowel wall in home, innervation of the bowel wall may be insufficient. Management of transanal migration. At first, we remove the shunt and shunt tip is sent for microbiological study. And we give prophylactic or empirical antibiotic therapy such as ceftriaxone, vancomycin, and metronidazole. When sign of raised ICP is present, we give acetozolamide and put EBD. Subsequent reinsertion of shunt in the presence of active hydrocephalus may be done between 6 and 12 weeks. Regarding removal of the shunt, we open the abdominal previous scar and cut the shunt, and peritoneal end of the shunt is pulled out through the anus, and another incision over the cranial side and upper end of the shunt is removed. It is another complication of BP shunt, intracranial migration. These are many factors that are proposed responsible for the migration of the shunt. Excessive neck movement producing windlass effect with large subgaleal space creating for bulb and dilated ventricles with negative functioning pressure with positive intra-abdominal pressure thought to be responsible for intracranial migration. The memory of the device placed in the packaging allows shunt tube to recoil, explained as memory phenomenon. Other factors are younger age, thin cortical mantle, malnutrition, large bar hole, wide dural opening, shunt catheter not anchoring to the pericardium, cylindrical bulb, especially in Chebra shunt, and straight course of shunt tunnel, also responsible for intracranial migration. To prevent intracranial migration, smaller dural opening, smaller bar hole, or anchoring to the pericardium is ensured. This is rare complication of BP shunt. It is intrathoracic migration. This child presented with severe respiratory distress and admitted in ICU. Chest X-ray showed intrathoracic migration of the lower end of the BP shunt, probably through diaphragm. Unfortunately, child died in ICU. Migration into the scrotum presented with scrotal swelling unobliterated processes vaginalis in pediatric patients lead to BP shunt distal catheter migration into the scrotum. This X-ray shows the scrotal migration of the BP shunt. Treatment is explosion of the inguinal region, reposition of the shunt, repair of processus vaginalis. Another common complication of BP shunt is over-drainage or over-shunting. Either may be seen as extracerebral fluid or blood collection, or may be classified as split ventricular syndrome. Subdural fluid collection due to collapse of the ventricles, subdural fluid collection can accumulate. Programmable valve can decrease or stopping over drainage. Treatment is subduroperitoneal shunt, of course, low pressure. In subdural hematoma, with collapse of the ventricles, blood can accumulate due to rupture of the breathing vein. Treatment is evacuation of hematoma by barhole aspiration. CT scan showed bilateral subdural hygroma, cause is over drainage of the shunt. Sudden decrease in ICP allows brain to fall away from the skull, opening up the subdural space. Vessels traversing the subdural space get stretched, resulting in transudation of fluid from the intravascular compartment to the subdural space. Treatment is barhole aspiration, but the result is unsatisfactory. Reaccumulation of fluid is common. So alternative option is low pressure subduroperitoneal shunt. Programmable shunt can decrease over drainage and ultimately subdural effusion. Subdural effusion coexisting with hydrocephalus secondary to CSF shunt under drainage. Extracerebral fluid collection is secondary to pressure-related CSF. It spills from the ventricles into the subdural space. Impaired physiological CSF drainage along Barker-Robin perivascular space in raised ICP. This CT scan showed subdural effusion with ventriculomegaly. Treatment is revision of BP shunt. Subdural hematoma, over drainage of shunt, sudden decrease in ICP allows the brain fall away from the skull. Rupture of the breathing vein causes subdural hematoma. This scan showed subdural hematoma. Treatment is barhole and evacuation of the hematoma. Programmable shunt can decrease over drainage and subdural hematoma. This is a picture of unfortunate girl, had hydrocephalus. We put a shunt and in postoperative period developed subdural hematoma. We did barhole and aspiration of the hematoma, but subsequently subdural hematoma developed. We did craniotomy and removal of the infective materials, but again developed subdural empyema. Slit ventricular syndrome, overdrain of CSF because of siphoning effect, small ventricle cause intermittent ventricular catheter obstruction, poor compensatory mechanism, poor brain compliance causes headache, nausea, vomiting, signs of raised ICP, ultimately coma. This is split ventricular syndrome due to over drainage of the CSF. Due to over drainage, shrunken skull. Big child with big head, we underwent BP shunt, and in postoperative period, shrunken skull developed. Loculation sequelae of ventriculitis, shunt will drain only a portion of ventricular system, leaving another one enlarged and causing mass effect. Image showed isolated lateral ventricle or isolated fourth ventricle. CT scan showed septated or loculated hydrocephalus. This is another CT scan showed septated or loculated hydrocephalus. Treatment is difficult. We do endoscopic septation or communication between loculation, and subsequently we put VP shunt. In debilitated patients with thin skull causes skin erosion over the shunt catheter. Skin is slapped out over the shunt catheter, shunt is exposed. Treatment is just secondary suture and improve the nutritional status of the child. This is another picture showed shunt extrusion through the skin in right lumbar region. Peritonitis is a rare complication. BP shunt is common association, infection, common association, conservative management with antibiotics. If fails, requires laparotomy. Intestinal obstruction is a rare complication of BP shunt surgery. Cause is adhesion or shunt knotting. Conservative management may improve this condition. If fails, require laparotomy. Picture shows lower end coiling. This picture shows peritoneal catheter coiled. This coiling does not always cause intestinal obstruction. This is complication of BP shunt. Peritoneal cavity unable to absorb frozen abdomen causes CSF ascites. Abdominal paracentesis may help the patient symptomatically, but recurrence is common. Alternative option is ventriculoatrial shunt. Pseudocyst or loculate pockets filled with unabsorbed CSF. Abdominal pseudocyst is a rare complication after BP shunt and could result in shunt malfunction or abdominal symptoms and signs. CT scan showed abdominal pseudocyst and peritoneal catheter confirmed by ultrasonography and CT scan of the abdomen. Treatment is open exploration, cyst fluid drain, partial or complete excision of the cyst wall, and reposition of the shunt. CSF leak may occur, common at cranial site. To prevent CSF leak, a smaller dural opening can help during insertion of the ventricular catheter. Picture showed large pseudomeningocele at cranial site due to CSF leak at cranial site. A smaller dural opening during insertion of the ventricular catheter prevent the CSF leak and subsequently pseudomeningocele. Seizure may occur, may associated with malformation of the cerebral cortex. We usually prophylactically give anticonvulsant during BP shunt surgery and in post-operative period. After BP shunt surgery, a child may have cognitive delay or motor disability. In our study, few child had walking difficulty, developmental delay. In our small study, only 41.27% had good outcome with normal development and normal IQ. In conclusions, insertion of ventriculoperitoneal shunt is routinely done by all neurosurgeons. Great care and precautions should be taken during insertion of the shunt system, starting from scrubbing to avoid complications such as infection. The advent of endoscopic third ventriculostomy has gained popularity due to the high complication and failure rates of ventriculoperitoneal shunt. Despite complications, ventriculoperitoneal shunt remains the main surgical procedure used for hydrocephalus management. This is end of my talk. I am stopping here. Thank you very much, everyone.
Okay, very good, Doc. Dr. Mukherjee, are you there? Okay.
Thank you, Dr. D.M. Arman, for your valuable and time-demanding talk. And I think this talk is essential for all neurosurgeons and all residents who are working in neurosurgery world. Even our ward sister have to know this idea that what are the symptom and sign of VP shunt complication and how they identify the patient very fast, very rapidly. My topics is ideal VP shunt. Actually, that is a unrealistic word. Actually, there is no ideal VP shunt, but we are searching. We are trying to find out something. For that endeavor, I want to present my topics and I want to share my screen. Please give me some time.
You're an expert.
So now is it okay, John?
Yeah, perfect.
Full screen. So welcome you all in today's third episode of our webcast. In these three episodes, we discuss regarding hydrocephalus management. We try to touch all the sites, even some part of management is still now not discussed. For CSF diversion, we are doing several procedures. Shunt is one of that procedure, and shunt is most widely and universally practiced for hydrocephalus management. Hydrocephalus has puzzled man since dawn of civilization. If you check the history, you saw there is a lot of diversity and lot of debate regarding hydrocephalus management. And VP shunt, it makes another puzzle for its stakeholder like doctor, like patient, guardian, manufacturer, designer. Everybody is puzzled regarding VP shunt also. That is my topics. Anatomy of VP shunt. A VP shunt has three parts. This is universal. That is a inflow that is called ventricular catheter, a valve mechanism which we usually put behind the air, and a outflow that is called peritoneal catheter, usually go to abdominal cavity. Most modern shunt catheter made of silicone, a straight configuration. Dr. D.M. Arman already say, if somebody put the shunt in a circular way, so it has some memory effect. Memory effect is bad. It can causes recoiling after implantation. So there is a chance of shunt migration due to memory effect. So a straight configuration, a straight packaging is better. BioGlide is a component. It can make shunt hydrophilic. So that water jacket prevents bacterial adherence in shunt wall. Though BioGlide is not practiced nowadays, company discontinued this product since 2010 as because it causes some mechanical problem like disconnection also. The ventricular catheter. Ventricular catheter usually 15 to 23 centimeter, 1 to 1.6 millimeter diameter, and 30% shunt complication, that means obstruction, occur in the ventricular catheter. There are different type of ventricular catheter is present. Like ventricular catheter is straight and ventricular catheter curved J shape. It has planes. It has a expandable ball in the tip. So this is a typical ventricular catheter where tip contains 3 to 4 row equally placed hole and hole 4 to 8 hole in each row and 0.2 to 5.5 millimeter tapering end, and it contains the hole. Distal catheter. Distal catheter length varies from 90 to 120 centimeter. Inner diameter is almost like ventricular catheter, 0.7 to 1.3. Catheter made of silicon polymer. Barium impregnation may done, but barium causes some problem in the elasticity for long term. It invites calcification and shunt tubing is hardened, so more prone to fracture. That's why barium is replaced by tantalum nowadays, because barium makes its radio opaque, it is true, but barium has some complication also. Distal part, there are slit catheter, and slit may be sticky. So by prevention of sticky, there is black graphite is given in the edge of the slit. So there is the important, and this is a very important shunt, is called antibiotic impregnated shunt or AIS. You know, the AIS, there are at least 3 good AIS shunt in the market, that is Bactisil by Codman, Aris Medtronic, and Silverline by Spiegelberg. Aris was available once upon a time in our country. They use clindamycin and rifampicin, which prevent the gram-positive infection at least 31 to 48 days. How shunt is made? Shunt is made by 5 material. One is silicon elastomer, and most of the shunt is developed by silicon elastomer. Polypropylene used by shunt seating and the hard shell. Titanium or stainless steel is used for making spring and other metallic part, valve housing. Tantalum used for as a radio opaque marker. Barium is radio opacifier. And another thing is not mentioned here, that is sometimes ruby ball is used in case of programmable shunt. This is the connector. There are different type of connector, like a straight connector, angulated connector, or bifurcated or Y-shaped connector. The upper two is the not connector. These are helpful for housing the ventricular part of the catheter, and it prevents migration of the shunt. This is the tunneling device. There are so many tunneling devices made customized by different manufacturers in different parts of the world. The traditional tunneling device, it has 2 parts, inner tube and outer tube, but some tunneling device has single tube only. So there are different type of tunneling device. There are disposable tunneling device, reusable tunneling device present also. The bulb has 3 types, that is bar hole type, the top one. The second one is flat bottom type. It is also called contoured shunt. That means it makes a good contour with the skull, and this is the Rickman cylindrical shunt made by Integra, the third one. Now, this is the important part of hydrodynamics, that how a shunt works. Shunt works by, valve works by pressure difference. When you open a door by pushing the door handle, when your pressure is more than the pressure of opposite side, so door is open. So that is the opening pressure. That is pressure difference at which valve is open. So in respect of opening pressure, there are 5 pressure available: very low, low, medium, and high. When door is closed, if the pressure in opposite side is more than pressure in your side, so door will close. So the pressure difference at which valve closes, that is called closing pressure. So opening pressure and closing pressure is important for differential pressure. That is the basic physics, hydrodynamics, or basic philosophy of shunt works. So this is a antibiotic impregnated catheter. So this is the 4 types of shunt valve. That is, first one is differential pressure valve. That is the original and oldest one. The second one is flow regulated valve. The third one is programmable or adjustable valve. And there is a gravitational valve, though it is not very widely used. So there are 4 types of valve, and another is antibiotic impregnated shunt. So this graph should be understood. This is important. See, there are 2 types of curves. If the opening and closing pressure is same, the curve is same. So, but graph is different, as because opening and closing pressure is not same. Why it is different? Why it makes a elbow? Because the shunt material elasticity, it is different. So this is called hysteresis, when increasing pressure and decreasing pressure graph is not same. So every shunt has its own inherent hysteresis, depends on the manufacturing material. Now, differential pressure valve. If you see a pressure cooker in your home, and if you have some cooking experience with pressure cooker, so you can understand a differential pressure valve very easily. When you boil something and water within the pressure cooker, the water produce some vapor. That vapor causes increased pressure within the pressure cooker. When the pressure limit crosses the valve pressure, so huge amount of vapor comes out. So that is a differential pressure valve used in the pressure cooker. Same technology used in a shunt for differential pressure. But differential pressure valve is the problem, it is fixed pressure shunt. It is not a adjustable pressure shunt. So these are 4 types of differential pressure valve. The first one, slit. Slit I will discuss later. The second one is diaphragm. You see, this is the Medtronic PS Medical contour valve. They use the diaphragm technology. The third one is mitral valve. You see the mitral valve here, the in the left side, this is the mitral valve. In the picture, it is the third one. And fourth one is metal spring ball valve or ball in cone. Ball in cone, in the lower right one is the ball in cone. So this is the widely used slit and spring valve. Actually, we used by Chebra Surgiware. Surgiware, the shunt name is Chebra shunt. You see the upper one, there is a plastic housing. there is a inflow side, plastic housing, outflow. And within the plastic housing, another plastic tube is there. Within the second plastic tube, there is a spring, steel spring. In the second plastic tube, there are four longitudinal slits. So that is the mechanism which causes open after pressure difference. So they have surgery have three types of shunt. They have low pressure, medium pressure, and high pressure shunt. So this is fixed pressure shunt, and they have this is open in the fixed pressure. So this is cheap but widely available, but this is fixed pressure. Now come to flow regulating shunt. This is the latest and this is the very good technology is the flow regulating valve. That means flow is constant, pressure difference whatever may be. So flow rate is constant. So it creates a sigmoid shape curve. In the middle part you see in the curve graph. In the second part of the graph, though there is high resistance, but flow is not increasing. So this is the main property of flow regulated shunt. Ideal shunt is flow regulated shunt. That is Medtronic PS Medical valve is flow regulated shunt. How flow regulated thinking comes in mind? Hiram Cod, an engineer in UK, he patented a cork mechanism of some soda water by which he made by a ball in the cone, tapering cone in the bottle. So here I make some draw the tapering cone of bottle, and there is a circular ball within the bottle. So if someone want to pressurize the bottle and makes more flow from the bottle mouth, so that is not possible. Ball will come in the bottle mouth and flow will reduce. So that is an important technique that you cannot use more soda water at a time. So it comes slowly and slowly in a fixed flow. He was the first man who used scientifically the flow control technique. This is his technique. Later in Japan, some soda water company, they use same technique also. This is a flow control valve. They use two membrane in which a piston, that piston is OS shape, that piston goes up and down in a same diameter hole of membrane. So when there is a chance of overflow, that piston goes down, so overflow will prevent it. So now flow control valve has some property. It is automatically adjusting, avoid rapid decrease of the ventricular size, deliver position independent. That means a person can supine, a person can standing, same flow will continue, and there is a less chance of over drainage, and contain non-ferromagnetic material, so not hampered by MRI, and it can use even in the high protein count, and it can maintain the physiological response, and there is a less chance of slit ventricle. So flow control valve has 9 facility over the differential pressure valve. And flow control valve has 3 stages. I show you in the graph already. That is low differential pressure, the first part of the graph. Then flow regulation in the second part of graph. That is the most important part of the sigmoid graph. And the last part, that is pressure relief mode. Sometimes there is very high pressure. So they can relieve some pressure in the third stage. There are so many configuration of flow control valve: double valve, inline valve, bar hole valve, nano valve for pediatrics, valve for infants, multi-stress flow control valve. So there are so many flow control valve. Now comes to adjustable or programmable valve. This is a device which control flow, but flow control parameter can change from outside by some magnetic rotor. So that is the actual difference in between a flow control valve and programmable flow control valve. You can change the flow control parameter in the first picture. You see there are some parameter in different stages. So you can change the flow control parameter by a magnetic rotor from outside without any intervention. So you can a patient can enjoy different type of parameter by single valve. That is the adjustable valve. The commonly used as adjustable valve, Sophie valve by Sophia, Strata valve that is most widely used one by Medtronic, Hakim programmable valve by Codman, ProGap by Esculap, Septas by Codman also. And flow control valve initial days, there are some MRI problem, but nowadays they use MRI friendly material, so it is not problematic. But the main problem of flow control valve is its price. Its price is 2 to 3 times more than traditional valve. So there are some example of flow control valves. One, this is a Codman valve. So this is the programming device working from outside. It has some foot. So foot should be given over the valve. So this is controlled by magnetic device from outside. And see, it can control the pressure from 30 millimeter to 200 millimeter water pressure. So it has 18 steps. That is the one of the best valve from Codman. Now come to important point: availability, affordability, and post-shunt maintenance is important for a flow control valve. Now comes to hydrodynamics. A shunt, how works? There is a pressure difference. Pressure difference is related to density of fluid, that means density of CSF, liquid height, that means patient is supine or patient is lying down, and gravity and resistance. So resistance is related with diameter of the tube, geometry, that means tube is curved, tube is straight, or turbulence, that is laminar flow or turbulent flow, viscosity of fluid. If high protein presence, so viscosity will rise, compliance of the shunt. So resistance is related to with some factor. So this is the first generation valve, that is the basic valve. Second generation is Orbis Sigma Delta. Delta is anti-gravity. I comes to the anti-siphon device or anti-gravity later. And programmable, among the programmable valve, Sophia, Codman, Strata, ProGap, Strata 2 or NSC, these are the better valve. This is a Strata 2 MR by Medtronic. It has a delta chamber, that means anti-gravity chamber in the distal part. So Medtronic MR2 has 5 performance level. This is the performance level. See, what is the significance of a flow control valve? In a flow control valve where there is no programming is possible, so it's work in a single graph. But in this case, you see there are 5 graphs, so patient can enjoy different graph as per necessity, and there are different graph for horizontal or vertical position also. So pressure flow performance level setting can be adjusted, designed to maintain equilibrium of CSF pressure, available in standard and small model. Injection can given through reservoir dome as well as CSF can collected. Proximal and distal occlude are present and latex free. Now come to anti-siphon device. Dr. D.M. Arman tell you the slit ventricle syndrome. Slit ventricle syndrome actually a great problem. He also said that some patients can die also due to slit ventricle syndrome. But if there is an anti-siphon device, there is a least chance of developing slit ventricle syndrome. What is anti-siphon device? Come to the point. See, in a standing position, intraventricular pressure, in a supine position, intraventricular pressure is different. In supine position, intraventricular pressure is more positive. And there is less hydrostatic pressure in supine position. So this is a picture of Newton who saw the apple going down. So that's why he thinking about the gravity. So we must thinking about the gravity and siphoning of the CSF to protect the slit ventricle syndrome and overdrainage. This is the device, how it works. See, there is a thin membrane over the shunt device in the inlet or outlet device. If atmospheric pressure is too high and too negative within the shunt, so the thin membrane comes to the valve, toward valve, and occlude the inlet or outlet at the same time. So that is the mechanism how anti-gravity device acts. See another example. This is a valve where the blue color is inlet, blue color on right side is outlet, and there is a thin membrane in one side. If there is a high positive pressure in atmosphere, that means patient in supine position, so the thin membrane comes to the material and the inlet is completely occluded. There is no chance of over drainage in standing position or no chance of over drainage even in swimming, in running. So in a traditional shunt without anti-gravity device, if baby is running in the field, so they feel headache. So they are not interested for outdoor play. But if they have an anti-gravity device, so there is no problem during running also. So this is another example of anti-gravity device. There are some company name like Radionics here, but the most widely available flow control valve is Delta. Now, this is a Strata NSC adjustable valve from Medtronics. See, there are different type of diaphragmatic membrane valve. This is a Codman valve, programmable valve. I already stated that 18 pressure setting in the Codman valve. The Asculap has a ProGap system. The ProGap system has 3 steps for reprogramming. See, the ProGap system works in supine position as well as horizontal position in a very well. Now come to the main theme, that an ideal shunt. Is it possible? Because there are so many pathology, so many age, and different type of shunt is available in different area of the world. So is there any ideal shunt? But what is the ideal shunt? The ideal shunt, the normal brain resorption of CSF into venous system via arachnoid granulation. So an ideal shunt should be mimics as a normal CSF resorption system. Second one, it control intracranial pressure like a normal brain. It handle various CSF pressure changes like horizontal position, standing, running, swimming, driving. In all position, it control a optimum CSF pressure change and reconstitute cerebral mantle. So 4 property is necessary for an ideal shunt. Is it possible? Currently, shunt allows for low resistance pathway for CSF diversion. An ideal shunt is like an ideal food. You see rice, you see shrimp, you see cassava, you see there are so many food all over the world. You see caviar, but is it available all over the world? If it is available, it is suitable for everyone. Is it somewhere very expensive like caviar? Is everybody afford it? Something may like cassava. Cassava causes you allergic reaction. So is it suitable for everybody? So there is no ideal food all over the world. There are several factors. In our zone, in our part of the world, rice is the staple food as because it is widely available, people can afford, and it is very friendly to human being. So the ideal food is different in different part of world for different people. Like a ideal shunt is different and customized for every individual in different setting. So a ideal shunt have 14 property. One, some important issue that hydrocephalus is not a disease. Hydrocephalus is a condition. Second, for patient, no shunt is best shunt. Not two hydrocephalus is same. Like two hydrocephalus always different. Treat patient as a whole, not to treat image. Sometimes in image we see hydrocephalus, but patient has no symptom. Head is not growing. There is no pressure effect. So why we go for operation? Commitment with a shunt is lifelong, like a marriage. So breaking of marriage is not good, and like breaking of commitment with a shunt is not good for patient and family also. Attempt shunt in a cleanest CSF, because if there is CSF infection or high protein or blood debris, we must do shunt when the CSF is the cleanest and infection free. Ventricular catheter is straight is good. Distal one is open-ended is good. Ventricular catheter length should be assessed before surgery. Choose appropriate flow pressure character. We know the best shunt is the flow regulated shunt. Adjustable or programmable shunt is better, is another best way. But where it is not available, what we can do in our place? Differential pressure valve widely used, as because not available flow pressure flow regulated shunt. So what we can do with patient? We cannot do operation. We must do operation. In some place, the flow regulated shunt is available. They can afford. In some place, flow regulated shunt not available. Check valve for any debris, clot or air. Connector or ligature should be tight enough. Silicone is the best material. Antibiotic impregnated shunt can reduce infection. Contour reservoir valve is better. Extremely malnourished patient may do rescue VSD rather than shunt. Programmable shunt, anti-siphon device, antibiotic impregnation is better but costly. Three-piece shunt is especially better for pets, pediatric, because in three-piece shunt, you can customize and small the abdominal end. When a shunt is fixed, a distal tube is fixed with valve, the problem you can put all the shunt tube in the pediatric abdomen, because the neonate, their abdominal volume is small. So shunt will make a coil. Sometimes it make a coil with the intestine. So there is a more chance of perforation, more chance to lower end malfunction. So now this is a small picture graph, that is the three important points for a shunt. Surgeon know the technique of relevant shunt hardware and property of that shunt. Shunt. Ideal shunt is flow control, shape, configuration, material, cost, availability, post-operative service, that is important for choose a shunt. So sometimes we can choose a shunt, a adjustable shunt, where the post-operative service, or that means reprogramming service is available. So we can use that. But in some manufacturer, they have no post-operative reprogramming service in some part of the world. So if someone use that shunt where the service is not available, that makes a serious trap for the patient. Patient will not get the post-operative service. The third one is the most important one is the patient. Patient is CSF composition. Three things is important like protein and infection and blood component. So these three things in case in CSF, any infection, active infection, ventricular configuration, and peritoneal environment. If a patient has a history of a frozen abdomen, that means abdominal malabsorption syndrome. So if we put a shunt again in the peritoneal cavity, it produces lower end malfunction and complication. So peritoneal environment is very important also. So what we can do in future? We use this shunt or we can do something good. We can think something good that make patients' life in a more carefree style. Patients and their guardians, they think that carefree lifestyle is important. The process of development and innovation of a shunt design is going on, and we still have a long way to go for an ideal shunt. So we have no ideal shunt still now. We are on the way for designing new things. So how we can develop? We can use nanotechnology for making the new shunt. If we develop three things, making nanosensor which can sensing the pressure automatically, and drainage system they can open as per necessary from the information from sensor. So it can prevent over drainage, under drainage, and if there is a good nanomotor, it can flash the proximal and distal part as per necessary. So a nano pump or nanomotor also necessary. And another important thing is a nanoguard. Nanoguard is a something which can sense, making sensor for infection in product or protein by nanoguard technique. So it can inform or give signal to outside to your device, outside device, that patient suffering or facing some high protein content or high infection is coming by nanoguard sensor. So shunt will more physiological environment in ventricular system. So thank you very much for hearing a very unpalatable but very necessary issue, because hydrocephalus is almost present all over the world. In some part of the world it is more, in some part of the world it is less, but it present all over the world, and sometimes the VP shunt is inevitable because endoscopic third ventriculostomy is not indicated or failed. So in that case, you have only one technique in your hand, that is VP shunt or other CSF diversion technique. So we need to improve our shunt system, but till that improvement, we should choose by customization of the shunt. If depends on your availability, affordability, and other resources. Thank you very much for hearing. Thank you.
Thanks, Dr. S.K. Mukherjee, for your excellent talk. I must say, it is not a simple talk. Bulb mechanism, hydrodynamics is a difficult subject, but you described nicely. We have learned a lot new things. Again, thank you very much, Dr. S.K. Mukherjee.
Most welcome.
Yes, thank you for taking the time for an excellent presentation.
Some question in the chat.
Yeah, I'm looking now. Any questions from the panelists
No question, comments.
or comments? Oh, Dr. Ayman, go ahead. Dr. Ayman, go ahead.
Hello.
Yes, hello.
Hello, nice
Okay.
to see you and meet me. And
Please introduce yourself.
Dr. Ayman, a neurosurgeon resident from Tripoli, Libya.
Dr.
Welcome.
Ayman, video, please. Okay.
Your
I have
question?
problem with my camera.
Yeah, okay.
Okay.
Take your time.
First of all, I would like to thank you, Dr. John, and all colleagues responsible about this broadcasting.
My pleasure.
I have learned a lot of this broadcasting, and it's an amazing idea. And we are so proud and pleasure to involve with this program. I'd like to ask Dr. Mukherjee about the shunt exposure, because I have seen a lot of cases, exposure on scalp area or neck area. I ask about the proper treatment. Is it shunt revision? We should remove the shunt and reinsert.
So that means your question is shunt exposed in the neck. That means his skin.
Sorry. I didn't hear you. Sorry.
So your question is when a patient shunt is exposed, the skin is necrosed or infected over the shunt.
Skin is ulcerated. Yeah.
The rule is when hardware is infected, you must remove it. There is no other option. But sometimes we can try to preserve it by closing, by making the secondary closure of the wound. But so far I remember in our setting, because we are doing, you saw that Dr. D.M. Arman, he showed we are doing in the about 1,000 shunt in last couple of years. Our experience, if we do secondary closure of the wound after subsiding the infection, patient will come again with infection. Even sometimes there is a bad infection, it will ascend usually or descend in the abdomen, and patient condition is more bad, worse. So the best thing, you can exteriorize the shunt if it is functioning. But if the shunt is not functioning at the same time, so you can remove it without any hesitation. But if this shunt is functioning, never remove it without any alternate way. But you can remove if there is a white fontanelle open, so you can remove with a thing that you can tap, do ventricular tap if necessary. Otherwise, you can do shunt externalization or giving a fresh CBD for externalization and wait till the CSF is clear. That means protein below 200, culture negative, no blood debris, to a endoscopic third ventriculostomy. This is the way. Sometimes shunt mechanically obstructed, but there is a peri-shunt fibrous sheath, make a tubular structure. So it covers CSF absorption within the fibrous tube, and CSF may trickle down through this functioning shunt is not a really non-functioning one. You can evaluate that thing also. Thank you, Dr. Ayman, for a valuable question.
Thank you. Highly appreciate it.
I contribute a small thing. It is common in debilitated patient where scalp is very thin, patient is malnourished. So nutritional status improvement is essential thing also.
Thank you.
Okay, very good. Two great discussions. Okay, any more comments or questions from any of the panelists? You can either type them in if you don't want to be on camera or just speak up. Anyone else want to just say hi, introduce themselves? This puts humanity
Or
back.
you can ask question. You
Go
can
ahead.
ask question for more clarification in our email address. That is, my email address is Dr. Sudipto,
Yeah, could you, put it in the
70
chat.
at the rate of hotmail.com, or you can send question to John Neurosurgical TV. He can forward to us.
Can you put your email on the chat right there? Because it makes it accessible.
Okay,
Just
sure,
just type it in the
sure.
chat real quick. And people would
Okay,
appreciate-
I can put my email.
Yeah, that would be good. If anyone wants to meet Dr. Mukherjee, just you have the email now. A lot
Dr.
of
DM
time-
Arman, you can put your email also in the chat box.
Yeah. Yeah, it's good. Sometimes you forget to get the email. And when this webcast ends, this email disappears. So now who else did you want to put the email? Someone else, right? Okay, does everybody have that access to the email? Dr. Shudipka, and you want another doctor put it in, right, Doc? You want another doctor to put his email in? Yeah, just put it in, Dr. Alman, if you would like to. Yeah, there you go. Okay, everybody, there's access to two of the speakers if you need to get a hold of them. This is a tight community and getting tighter.
Most
Okay,
welcome.
very good. Okay. So I guess Dr. Mukherjee, I guess the next topic next week is also hydrocephalus or 2 weeks,
Next,
2 weeks.
I think
no, next 2 weeks later.
tumor. Brain tumor.
Yes.
Okay.
2 weeks later, we have a plan to broadcast posterior fossa tumor in pediatrics. We divide it into posterior fossa tumor and another for supratentorial tumor, and if necessary, more than one sitting for one issue.
One webcast. Okay, you're also welcome to do next week if you want.
Okay.
If you don't want, we can do it in 2 weeks.
Okay, 2 weeks is better for preparation.
Okay, that's fine. That's fine. Okay, everyone, thank you very much for interacting and thank you. We'll see you in 2 weeks.
Thank you, everyone.
Thanks.
Okay, very good.